Good morning. This is Dr. Raju Devde, Professor in Kakatiya Medical College, Warangal. Today, the topic for discussion is immunopharmacology. In this immunopharmacology, I'll be dealing in the following headings: introduction, definition, types of immune responses like innate immune response and acquired immune response. I'll be discussing about the abnormal immune responses, in which the broad topic in immunopharmacology will be immunosuppressants, immunostimulants, and monoclonal antibodies. Now, when we talk about the introduction of immunopharmacology, the basic idea of the immune system is to discriminate self from non-self. And the immune system is evolved to protect the multicellular organisms from the pathogens. And the protection is mainly by two activities. Number one, the recognition and the response. That is recognition to the antigen of the foreign body and the response to this particular antigen. Now, the definition of immunopharmacology. It is the study of drugs altering or modifying the immune response of the body. So, immunopharmacology is the study of drugs altering or modifying the immune response of the body. What is immunotherapy? It is nothing but the clinical application of knowledge gained from the study of immunopharmacology. Now, if you look at this slide, this is the basic cell, that is the hemocytoblast, from where we develop so many other different types of cells like proerythroblast, myeloblast, lymphoblast, monoblast, and megakaryoblast. And from this proerythroblast, the cells which are derived are the erythrocytes or the red blood cells. Okay, and from myeloblast, which results in the formation of progranulocyte, and this progranulocyte leads to the formation of a basophil, the eosinophil, and neutrophil. So the basophil, eosinophil, and neutrophil are derived from myeloblast, which are the granulocytes. And apart from that, the lymphoblast, which results in the development of lymphocyte, and there's another cell which is called as a monoblast. From hemocytoblast, another cell which is called as monoblast, which will lead to the formation of a monocyte. And this lymphocyte and monocytes, they are agranulocytes. So the granulocytes are the basophils, eosinophils, neutrophils. Agranulocytes are the lymphocyte and monocytes. And all these granulocytes and agranulocytes put together, they are called as leukocytes. Then when you look into this megakaryoblast, it goes to the formation of megakaryocyte, which results in the development of thrombocytes or the platelets. So this is how the cells are generated through the bone marrow. Now, when you look into the various types of immune responses, there are normal immune responses and abnormal immune responses. When we talk about this normal immune response, it is further divided into innate immune response and acquired immune response. And when you talk about this abnormal immune responses, these abnormal immune responses are also called as hypersensitivity reactions. So these hypersensitivity reactions, when you talk about, they are either antibody mediated or cell mediated. That is the abnormal immune response or hypersensitivity responses. There are two types. One is antibody mediated immune responses and cell mediated immune responses. And these, they are further classified into type 1, type 2, type 3, type 4 hypersensitivity reactions. Out of these four types of hypersensitivity reactions or abnormal immune responses, type 1, type 2 and type 3, type 1, type 2, type 3, they are antibody mediated, whereas the type 4, it is the cell mediated immunity or cell mediated hypersensitivity or immune response. Type 1, type 2, type 3 are antibody mediated, and type 4 is cell mediated. And this type of, all these types of abnormal immune responses, they mainly occur in two phases. Number one, sensitization phase. So what is this sensitization phase? So this is an initial encounter with an antigen. This is exactly, the sensitization phase is exactly an initial encounter with an antigen. Then the second phase is called as effector phase. The effector phase actually involves the immunological memory to the tissue pathology upon a subsequent encounter with the particular antigen which was occurred in the sensitization phase. So what is the effector phase? Effector phase mainly involves the immunological memory, that is nothing but which occurs as a tissue pathology upon subsequent encounter of that particular antigen which was previously exposed. So the abnormal immune response occurs in two phases. One is the sensitization phase, or the phase of initial encounter with an antigen. The effector phase involves the immunological memory which occurs as a tissue pathology upon subsequent encounter with that particular antigen. Now, we look into what is the innate immune response. So this innate immune response, it includes the physical, chemical, and cellular barriers. So what are the physical barriers of innate immune response? They are the skin and mucous membranes. The chemical barriers are the proteins, the peptides, which include the complement system, the lysozyme, and the interferons. Whereas when we look into the cellular barriers of innate immune response, they are the phagocytes, natural killer cells, and the dendritic cells. So these are the barriers, like physical, chemical, and cellular barriers associated with innate immune response. Then, what are the characteristic features of innate immune response? When you talk about innate immune response, it is of immediate onset of action. So there's an immediate onset of action with innate immune response. Then number two, antigen recognition by such receptors that can identify common molecules on the microbial cell surface. And number three, there is an involvement of macrophages, dendritic cells, neutrophils, mast cells, the complement system, interferons, and the natural killer cells. These are the typical characteristic features of innate immune response. So what are the functions of innate immune response? The function of innate immune response are nothing but, number one, phagocytosis. So they cause phagocytosis, which is opsonin dependent and opsonin independent. So opsonin dependent and opsonin independent phagocytosis is one of the major functions with innate immune response. Apart from that, number two, the presentation of processed antigens together with major histocompatibility protein 2 on the surface of antigen presenting cell, which is also called as accessory cell. That means to say, the second and foremost function of innate immune response is the presentation of processed antigens together with the major histocompatibility proteins, like histocompatibility proteins 2 on the surface of antigen presenting cell or the accessory cell. Then number three, to secrete proper soluble mediators and to produce cytokines is the major function. Now, when we talk about this complement system, because we have come across the complement system, so what is this complement system? This complement system, it comprises mainly of 20 normally inactive proteins in the plasma and on the cell membranes, and 11 complement proteins which are marked from C1 to C9, and next one is the classical complement proteins. They are with a formation of antigen antibody complexes, and alternative proteins which are nothing but polysaccharides and endotoxins which activate the C3 pathway directly. So here the 11 complement proteins which are marked from C1 to C9, the classical complement proteins which are initiated by the formation of antigen antibody complex, and alternative complement proteins which are the polysaccharides and endotoxins that activate the C3 pathway directly. And when you talk about the actions or functions of this complement system, the actions are mediated by three processes with the help of the complement system. They are the chemotaxis, the opsonization, and cytolysis. So these are the three major actions of the complement system. Then as we move forward, if you look into this particular pathway of the complement system, we have these pathways like classic pathway, MB-lectin pathway, and alternative pathway. So if you look at this classical pathway, there's a formation of antigen antibody complexes which are present on the pathogen surfaces. And not only that, they will result in the formation of C1q, C1r, C15, and C14 and C1C2. Then, and this MB-lectin pathway and alternative pathway, which is also present on the pathogen surfaces, which results in the formation of the major pathway, that is C3 complement pathway. And all these will come and converge at a enzyme which is called as complement 3 convertase enzyme, which again will result in the formation C1a, C5a. And this C1a, C5a will result in the peptide mediated formation of peptide mediators of inflammation and phagocyte recruitment, which will occur. Then there is another pathway from C3 convertase of these three major pathways. It will result in the formation of C3b, which binds to the complement receptors on the phagocytes, leading to opsonization of the pathogens and removal of the immune complexes. Then later on, this C3b will again result in the terminal complement components, formation of terminal complement components like C5b, C6, 7, 8, 9, and these in turn will cause the membrane to attack the complex, and lysis of certain pathogens and cells will occur. So this is actually the various pathways which are implicated with the complement system. Now, what is this acquired immune response? Till now we have seen the innate immune response. So what is acquired immune response? And the characteristic features of acquired immune response. So the main characteristic features are the acquired immune response. It responds to the specific antigen and antigens, and it discriminates between non-self and self antigens. Acquired immune response will discriminate between non-self and self antigens. And number 3, it responds to previously encountered antigen in more specific manner by the memory cells. And this acquired immune response, again, it is classified into two types. One is the cell mediated immunity, and number 2, that is humoral immunity. Now, what is the cellular immunity? The cellular immunity, it is mediated by the T lymphocytes, and this T cells or the T cells recognize the specific major histocompatibility complex, one that is antigen complex, and lyse the cells by perforins, and these perforins and lyse the cells by perforins and granzymes. Okay, granizymes. This T cells may be generated with or without the support of T helper cells 1, with or without the help of support of T helper cells 1, and all the T cells express an major histocompatibility antigen complex specific receptor designated as the T cell receptor. That is, TCR is nothing but the T cell receptors. Now, what is the cellular immunity? What are the functions of the cellular immunity? They are active against intracellular pathogen. Their function is against the cancer cells. Their function of the cellular immunity is against tissue transplants. So cellular immunity, the major three functions are, they are acting against intracellular pathogens, they are acting against the cancer cells, as well as against the tissue transplants. So what are the types of cell mediated immunity? The cell mediated immunity involving the T helper cells 1 mediated activation of the T cells, and this cell mediated immunity involves the direct role of CD8 and T lymphocytes. Okay, they involve directly the role of CD8 cells, and that is cluster of differentiation cells plus the T lymphocytes. Now, when we look into this humoral response and the cellular response, if you see, this is a foreign body or an antigen. This will cause the macrophage to produce the CD4 cell or the helper T cell. And this CD4 cell in turn will cause the release of cytokines, and these cytokines will act upon B cell and later on the plasma cell. Whereas here the CD4 cell will stimulate the cytokines, and this will cause the action on the cytotoxic T cell, will result in the active causation of active cytotoxic T cell. That is cellular response. And here in the humoral response, that is helper T cell, CD4 cell, helper T cell, with the help of cytokines to B cell and plasma cell. Here it is cytotoxic T cell and active cytotoxic T cell in the cellular response. What is humoral immunity? The humoral immunity, the antigen is processed by the B cells, and resulting peptides, which are complexed with major histocompatibility complex protein 2, are presented to the CD4 cells and the T helper cells. That is, the T helper cells secrete interleukin 4, 5, interleukin 10 for the beta cell or B cell proliferation and differentiation into the memory and the plasma cells. And it mainly, the humoral immunity works against the extracellular pathogens and antigens dissolved in the body fluids. Now, what are the various antibodies? The various antibodies you have to remember, that is immunoglobulins, GAMDE. Please remember GAMDE, GAMDE, that is immunoglobulin G, immunoglobulin A, IgM, IgD, and IgE. Very easy to remember. And the percentage of these antibodies also will go in the decreasing order of their percentage. For example, immunoglobulin G is 75%, and it enhances the phagocytosis or activate the complement system. Immunoglobulin A, it is 15%, and it is helpful for protection on the mucous membranes. Immunoglobulin M, which is 5 to 10%, it causes agglutination and lysis of the microbes. Immunoglobulin D, which is 1%, it is involved in activation of B cells and also serve as an antigen, as antigen receptors. Immunoglobulin E, this immunoglobulin E, it is located on the mast cells and involved in the allergic reaction. So please remember, immunoglobulin G, it is a very important immunoglobulin with 75% availability, and it enhances the phagocytosis and activate the complement system. And this is the only immunoglobulin which can cross the placental barrier. So it is just like Ganga. IgG means Ganga. Ganga is Ganga bahti hai. So this immunoglobulin G can cross the placental barrier, and it can reach the fetus. This is the only immunoglobulin I think which can cross the placental barrier, like immunoglobulin G for immunoglobulin G, or like Ganga, which can flow from the placenta to the fetus. And IgE is located especially on the mast cells and involved in the allergic reactions. Now, when you look at this particular slide, it depicts the structure of the immunoglobulin. So this immunoglobulin, it contains heavy chains. This is a heavy chain. This heavy chain is also called as FC fragment. This heavy chain, the blue one, this heavy chain is also called as the FC fragment, which lacks the ability to bind. Okay, it does not have the ability to bind. So whereas this pink one, this is called as the light chain, or it is also called as Fab fraction. This is called as Fab fraction. This is called as FC fraction, or Fab fraction, or FC fraction. So this Fab fraction, which has also called as a light chain, it has the ability to bind to the antigen. So this is called as the antigen binding site. So it can bind with the antigen, and this is a variable, and this is the constant. So this is called as the variable portion, and this is called the constant portion, and this is the antigen binding site. So FC chain, or FC fragment, or Fab fragment, or Fab fraction, which is called as the light chain, and FC fraction is called as the heavy chain. It does not have the ability to bind with the antigen. So this is the structure of the immunoglobulin. When we talk about this hypersensitivity, we talk about the responses. Responses, they occur in phases. So these two phases of immune responses are nothing but the antibody-mediated immune responses and the cell-mediated immune responses. They are the cell-mediated immune responses. Okay, there's some clumsy, there's some problem with the slides, but no problem. We'll just discuss about that. Yeah. Yeah, no problem. Yeah. Okay, so we'll discuss about what is called as the hypersensitivity reactions. As I already told you, this hypersensitivity reactions are type 1, type 2, type 3, and type 4. Okay, so this type 1, type 2, type 3 are antibody mediated, and type 4 is the cell mediated immune response. So when you talk about these, as I told you, this hypersensitivity reaction, it mainly occurs in two phases. Number one, which is called as sensitization phase, and number two, which is called as the effector phase. Okay, so the sensitization phase is an initial encounter with the antigen, and the effector phase is the involvement of the immunological memory resulting in the tissue pathology upon subsequent encounter of that previous antigen which was exposed to. Okay, now we have come to the slides exactly. So here, this abnormal immune responses, they result in extensive tissue damage, which is called as hypersensitivity reactions. Then abnormal immune responses will also result in the formation of reactivity against the self antigens, which is called as autoimmunity, resulting in various autoimmune disorders. Then when you look into the impaired reactivity, which is called as immunodeficiency. So the abnormal immune response can be an hypersensitivity reaction. It could be a reactivity against the self antigens, resulting in autoimmunity or autoimmune disorders, or there might be an impaired reactivity resulting in an immunodeficiency like state. Okay, so these are the three abnormal immune responses. So we will discuss about the hypersensitivity reactions, which I told you, which occurs in the two phases, the sensitization and the effector phase. Now, what are the various abnormal immune responses? Number one, that is type 1. Actually, as I told you, this type 1, type 2, and type 3 are antibody mediated, and type 4 is cell mediated. So what is this type 1? This type 1, it is an immediate IgE mediated abnormal immune response or hypersensitivity reaction. And the signs and symptoms of this type 1 occur within a few minutes, and due to release of histamine, due to the release of leukotrienes, due to the release of eosinophilic chemotactic factor, which results in the production of anaphylaxis, it results in the production of asthma, hay fever, urticaria, and these presentations with an immediate onset, which is IgE mediated, may result in an immediate medical intervention. Otherwise, the person may result in fatality, or may result in an abnormal, or may result in an emergency leading to death. due to anaphylaxis. Number two, the type 2 hypersensitivity reaction. It is mainly due to the formation of antigen antibody complexes between a foreign antigen and immunoglobulin M or immunoglobulin G. And the examples of these are, number one, blood transfusion reactions. So what exactly happens in this blood transfusion reaction? If the blood which has to be given or transfused is not cross-matched properly, what will happen? So the preformed antibodies bind to the RBC membrane antigens, which later on activate the complement cascade, generating a membrane attack complex that lyses the transfused RBCs, and hence there is hemolysis. So this is what is called as a blood transfusion reaction. Then another example of this type 2 hypersensitivity is hemolytic disease of the newborn. It is also called as erythroblastosis fetalis. So in this erythroblastosis fetalis, the anti-RH IgG antibodies produced by an Rh negative mother cross the placenta, bind the RBCs of the Rh positive fetus and damage them. So what happens? The anti-Rh IgG antibodies produced by an Rh negative mother cross the placenta, bind the RBCs of the Rh positive fetus and damage them. If or it can be prevented in the subsequent pregnancies by administration of anti-Rh antibodies to the mother within 24 to 48 hours after delivery. So this is how we can prevent the alternate pregnancies from getting death, or the alternate babies from getting dying with a hemolytic disease of the newborn. How? It can be prevented in subsequent pregnancies by administration of anti-Rh antibodies to the mother within 24 to 48 hours after the delivery. Then the last one is the example of type 2 hypersensitivity reaction is drug induced. So it can be drug induced, especially patients who are allergic to penicillin. Especially this type 2 reaction occurs where the penicillin binds to the RBCs or other host tissues to form a neoantigen, which evokes production of antibodies capable of inducing complement mediated RBC lysis. And in some situations, subsequent administration of that particular drug will result in a systemic anaphylaxis, a type of reaction which is mimicking the type 1 hypersensitivity reaction. Okay, so these are the three classical examples of type 2 hypersensitivity reactions. Then when we look into the type 3 hypersensitivity reaction, it is mainly due to increased levels of antigen antibody complexes in the circulation, which deposit on the basement membranes in the tissues and vessels. So here, the classical examples of type 3 hypersensitivity is the skin rashes, the glomerulonephritis, the arthritis. And the clinical symptoms of type 3 hypersensitivity will occur within 3 to 4 days after exposure to the antigen. Okay, so here the basic type 3 is due to an immune complex deposition of the basement membranes in the tissues and the blood vessels, which activate the complement to produce anaphylactoxic and chemotactic activities, and which causes a skin reactions, glomerulonephritis, and arthritis. Now, when you talk about type 4, it is the cell-mediated type of hypersensitivity reaction. And this type 4 is typically a delayed type of hypersensitivity reaction, and it may take around 2 to 3 days after exposure to the sensitizing antigen. And it is very effective in eliminating the infections or cellular parasites like the tuberculosis and leishmaniasis. Okay, and the clinical manifestations of this type 4 hypersensitivity especially can be seen when you do a tuberculin test or a tuberculin test and contact hypersensitivity reaction. Example, if you look into the tuberculosis TB exposure to delayed type of hypersensitivity skin test, can be tested by giving a tuberculin test. And there's one more example here where the poison ivy, most common cause of contact hypersensitivity. It is the commonest cause of contact hypersensitivity. And in this poison ivy, what does it do? It causes a production of pentadecacatechol. Also, it is this poison ivy is a lipophilic chemical which modifies the cellular tissue and results in a delayed type of hypersensitivity, which is a T cell response. So here, the classical examples here are the tuberculin test and contact hypersensitivity reaction, which is mainly seen with either tuberculosis or the tuberculin test or the poison ivy. So that is the classical examples of type 4 hypersensitivity, which is a cell-mediated type of hypersensitivity reactions. Then, now we will look into the various drugs which are affecting the which is going to affect the immunopharmacology, the immune system in pharmacology. So here, these drugs, they are categorized as immunomodulators. So what are these immunomodulators? So these immunomodulators are nothing but the drugs which modify the immune response. They modify the immune responses and are known as immunomodulators. So these immunomodulators, they are going to modify the immune response. So this immune response modifiers, they are further classified into three types. One is the immune suppressants, the immune stimulants, and the tolerogens. And these drugs are used in various autoimmune diseases and the transplant, graft host transplant rejection reactions. They are helpful in the treatment of graft host rejection transplant reactions. Now, when you talk about these immune suppressants, so these immune suppressants are the drugs which can dampen the immune response in organs and in organ transplantation and autoimmune diseases. In transplantations, we have major classes of drugs available are the glucocorticoids, the calcineurin inhibitors, the anti-proliferative and anti-metabolic agents, and number 4, the biologicals, they are called as antibodies. Okay, so the 4 groups of drugs are the corticosteroids, the calcineurin inhibitors, anti-proliferative or anti-metabolic agents, and the biological agents, which are nothing but the antibodies. Now, if you look at this particular, the immune suppressor, how they act, that is, APC is nothing but antigen presenting. This is an antigen presenting cell. So when this antigen presenting cell will result in the various cascade of events which can occur, and this is where actually the immune suppressants are going to act. So these immune suppressants are acting here at the level of the interleukins pathway and interferon N gamma. Then we have interleukin 12, then interleukin 4. And here, actually, there are the 2 phases. One, the antigen presentation cell, that is the APC, antigen presentation cell, where these steps will occur. And then we have a clonal expansion and maturation phase, where there's the formation of antibodies and the effector phase, and the entire antigen presentation and clonal expansion and maturation phase. It is called as it is called as induction phase. And the formation of antibodies and antibody mediated reactions and this glucocorticoids which are acting on the T helper cells and activating cytokines and other inhibiting these things, the kill virally infected cells, the cell mediated reactions, and all these things come under the effector phase. So we have an induction phase and effector phase when the antigen presenting cell gets presented with the immune suppressants being acting on these steps, and the glucocorticoids, they're acting here. Now, the adrenocortical steroids or the glucocorticoids. Adrenocortical steroids are glucocorticoids. In 1960, glucocorticoids were used as immunosuppressive drugs, played a key role in making organ transplantation possible. And the drugs like prednisolone, and other immune suppressives in combination used for the treatment of transplant rejection and autoimmune diseases. So prednisone and prednisolone were used in 1960s, especially the major glucocorticoids, which played a key role in making the organ transplantation possible in the year 1960. So what is the mechanism of action of these glucocorticoids? The glucocorticoids, they lyse and induce the redistribution of lymphocytes. They regulate the transcription of numerous other genes. They inhibit activation of NF-kB, that is nuclear factor Kb, and increases the apoptosis of the activated cells. And the cytokines such as IL-1 and IL-6 are downregulated. So you know now in this particular pandemic, like the corona pandemic, there is a cytokine storm, and especially with the release of interleukin 6, which is resulting in severe shortness of breath. So this interleukin 6 has become a very important marker for the prognosis of the corona pandemic. So the mainstay of this particular corona pandemic is the glucocorticoids. Okay, so we are giving the corticosteroids to prevent the cytokine storm, especially the IL-6, which is expressed in the corona pandemic. So the T cells inhibited from making interleukin 2, and this glucocorticoids or corticosteroids also inhibit the activation of cytotoxic lymphocytes. Then what are the therapeutic uses of glucocorticoids or adrenocorticosteroids? They are used to prevent and treat the transplant rejections. In high dose pulses of intravenous methylprednisolone succinate are used to reverse acute transplant rejection. For the treatment of graft host versus host disease in the bone marrow transplantation, in the treatment of rheumatoid arthritis, in the treatment of SLE, psoriasis, asthma, allergic diseases, and also of late, glucocorticoids are also having a main role to play in prevention of the cytokine storm, and which is resulting in causation of severe acute shortness of breath and death in patients with corona, that is COVID-19. So that is also one of the major use of glucocorticoids, which is suppressing the interleukin 6 production. Now, when you talk about the adverse drug reactions of glucocorticoids, they cause, on chronic use, they cause growth retardation in children, avascular necrosis of the bone, osteopenia, hyperglycemia, hypertension, poor wound healing, increased risk of infections, and posterior capsular cataracts especially. They also cause thinning of the skin. They also cause the development of opportunistic infections. They also cause the development of opportunistic infections. Now, we talk about calcineurin inhibitors. So what are these calcineurin inhibitors? The calcineurin inhibitors are nothing but the cyclosporin. The cyclosporin, it is produced by a fungus, Beauveria nivea. And the mechanism of action of cyclosporin is it acts by inhibiting the antigen-triggered signal transduction in the T lymphocytes. It also causes blunting expression of the lymphokines like I-interleukin 2, and it also causes expression of anti-apoptotic proteins. It also increases the expression of TGF-beta, and a potent inhibitor of interleukin 2 stimulated T cell proliferation. So these are all the mechanism of action of your calcineurin inhibitors like the cyclosporin. If you look at this cyclosporin, this is a T cell receptor, and there's a calcineurin A and calcineurin 2, and it acts by inhibiting at this particular level, and which causes an inhibition of the release of IL-2 through the nucleus. Then what are the preparations of this calcineurin inhibitors like cyclosporin? So intravenous preparations are available. It is available as sand immune, and they are provided as solution in ethanol, polyoxyethylated castor oil vehicle that is further diluted in sodium chloride. The oral dosage form is also available, which is nothing but the soft gelatin capsules and oral solutions. The bioavailability in the form of capsule is 20 to 50%, and they are also present as modified microemulsion formulation, which is called as neoral, and more uniform and slightly increased bioavailability is seen when compared to that of the soft gelatin capsules and the oral solutions. And it is provided as 25 milligrams and 100 milligrams as soft capsules. So what are the therapeutic uses of calcineurin inhibitors like cyclosporin? So it is mainly used in organ transplantation like the kidney transplant, liver transplant, and heart transplant to prevent graft host rejection. It is also used in the treatment of rheumatoid arthritis. It is also used in the treatment of psoriasis. Whereas cyclosporin, it is usually combined with other agents, especially the glucocorticoids, and it can also be combined with another drug which is called as azathioprine. So when we talk about the adverse drug reactions of cyclosporin, they cause renal dysfunction, they cause hypertension, tremor, hirsutism, hyperlipidemia, gingival hyperplasia, hyperuricemia, hypercholesterolemia are all the side effects of cyclosporin, that is your calcineurin inhibitors. So when we talk about this tacrolimus, so this tacrolimus is a macrolide antibiotic produced by Streptomyces succubensis. Streptomyces succubensis is derived from, it's a macrolide antibiotic derived from Streptomyces succubensis species. And the mechanism of action of tacrolimus is it acts by inhibiting the T cell activation by inhibiting the calcineurin receptors. And the tacrolimus binds to an intracellular protein which is called as FK506 binding protein 12 and immunophilin structurally related to cyclophilin. Immunophilin which is structurally related to cyclophilin. Now, when you talk about the preparations of tacrolimus, it is available as oral preparation in the form of capsules, 0.5 and 1 and 1.5 milligrams. And in the form of injections, it is available as solution for injection, that is 5 milligram per ml. And that the trough drug levels seem to correlate better with clinical events. And the target concentrations are 10 to 15 nanograms per ml in early pre-operative period with the help of tacrolimus, which has to be given in the pre-operative period to prevent the graft host rejection, and 100 to 200 nanograms per ml 3 months after transplantation is also given, that is tacrolimus. What are the uses of this tacrolimus? It is used for prophylaxis of solid organ allograft rejection, and the recommended initial oral doses are 0.2 milligrams per kg per day for adult kidney transplant patients, 0.1 to 0.15 milligrams per kg per day for liver transplantations, 0.075 mg per kg per day for heart transplant patients, 0.15 to 0.2 milligrams per kg per day for pediatric liver transplant patients. So here, if you look at the pediatric liver transplant patients, the dose given is more when compared to that of adult liver transplant patients. So it is 0.1 to 0.15 in adult liver transplant patient, whereas 0.15 to 0.2 milligrams per kg per day for pediatric liver transplant patients. Then when you look into the adverse drug reactions, they are the nephrotoxicity, neurotoxicity. Yeah, the nephrotoxicity, the neurotoxicity, hypertension, hyperkalemia, glucose intolerance, diabetes mellitus, increased risk of secondary tumors and infections are seen with tacrolimus. So what are the newer immunosuppressant drugs? They are ISATX 247, which is the new oral semi-synthetic analog of cyclosporin, and some preclinical studies have shown the reduction in the nephrotoxicity, which is seen with other drugs, and this has already gone into the phase 3, phase 2 and phase 3 clinical trials are in progress. And there's another drug which is called as CP690550, which inhibits the tyrosine kinase involved in the cell signaling, and the preclinical studies show no nephrotoxicity with this particular CP690550 compound, and it is currently in the clinical trials. Now coming to the protein kinase C inhibitor, that is AEBO71, which is having a very low molecular weight compound that blocks the T cell activation by inhibition of PKC. They cause inhibition of protein kinase C, and the clinical studies are ongoing. So when you talk about this anti-proliferative and anti-metabolic drugs, anti-proliferative and anti-metabolic drugs, they are the sirolimus. So the sirolimus, it is mainly produced by Streptomyces hygroscopicus, Streptomyces hygroscopicus. And the mechanism of action of sirolimus is it acts by inhibiting the T lymphocyte activation and proliferation downstream of the interleukin 2 and T cell growth factor receptors. They are called as PSIs. The PSIs are nothing but the proliferation signal inhibitors. So the cell growth factor receptors are these particular drugs, especially they are called as proliferation signal inhibitors. So the sirolimus acts by inhibiting the T lymphocytes activation and proliferation downstream of the interleukin 2 and the T cell growth factor receptors, which are called as proliferation signal inhibitors. They also cause the formation of a complex with an immunophilin, which is called as FKBP12 protein, and it binds and inhibits a protein kinase designated as mTOR. So okay, so the preparations and pharmacokinetics of sirolimus. So sirolimus is available as oral administration. So oral administration, it is very well absorbed, rapidly absorbed, and reaches a peak blood concentration of within 1 hour after a single dose and within 2 hours after multiple oral doses in renal transplant patient. And the systemic availability is 15%, and the blood concentrations proportional to doses between 3 and 12 milligrams per square meter body surface area, extensively metabolized by cytochrome 3A4, and it has a plasma half-life of 62 hours. That is sirolimus. It is also called as rapamycin. Therapeutic uses of sirolimus for prophylaxis of organ transplant rejection. The dosing regimens are with blood levels 5 to 15 nanograms per ml, and it is also, the sirolimus is also incorporated into the stents. So what are the adverse effects? The sirolimus causes an increase in the serum cholesterol and the triglyceride levels. It causes prolonged delayed graft function. It causes a lymphocyte development, delayed wound healing, hepatic artery thrombosis, and bronchial anastomotic dehiscence may also occur with as an adverse drug reaction to sirolimus. What is everolimus? So everolimus, the mechanism of action is similar to sirolimus, but it has a shorter half-life when compared to that is sirolimus. And along with, it is used along with a calcineurin inhibitor and enhances the toxicity and reduces the rejection. Then we'll come to azathioprine. It is an antimetabolite drug. So it is a purine antimetabolite drug. It is imidazolil derivative of 6-mercaptopurine, and it was introduced into the market in 1961 as an immunosuppressive agent. So the mechanism of action of azathioprine, it is acting by cleaving azathioprine is cleaved to 6-mercaptopurine, which then inhibits the purine synthesis. That is 6-thio-IMP is converted to 6-thio-GMP and then to 6-thio-GTP, which is incorporated into the DNA. Then, if you look at this azathioprine, this is the molecule actually, the methyl and NO2. Okay, and then this is the area. So the dotted line which indicates where the molecule is cleaved to release the mercaptopurine. This is the structure of azathioprine. So what are the preparations and pharmacokinetics of azathioprine? It is very well absorbed orally. It has a plasma half-life of 10 minutes. And the therapeutic uses are, it is used as an adjunct for prevention of organ transplant rejection. And also it is used in the treatment of severe rheumatoid arthritis. The adverse effects are mainly the bone marrow suppression and hepatotoxicity. Okay, then we have another drug which is called as mycophenolate mofetil. So actually this mycophenolate mofetil, it is a prodrug. And this mycophenolate mofetil is converted into its active compound which is called as mycophenolic acid. And the mechanism of action is it acts by reversible inhibition of inosine monophosphate dehydrogenase, an enzyme in guanine nucleotide synthesis. And as I told you, it is converted to mycophenolic acid, which is an active compound of mycophenolate mofetil. And this mycophenolic acid selectively inhibits the lymphocyte proliferation and functions. And the pharmacokinetics of mycophenolate mofetil is it is rapidly converted to mycophenolic acid, and the plasma half-life of mycophenolic acid is 16 hours. Coming to the therapeutic uses, when it is used, it can be used orally or intravenously 1 gram twice daily. It is used as a delayed release tablet of mycophenolic acid, which is also available, and it is used for the prophylaxis of transplant rejections. When you look into the adverse drug reactions of mycophenolate, it causes leukopenia, pure red cell aplasia, progressive multifocal leukoencephalopathy, interstitial nephritis. And in pregnancy, it may also cause congenital anomalies and increased risk of the loss of pregnancy. Then coming to the other aspect, which is called as biological immunosuppression. So what is this biological immunosuppression? This biological immunosuppression is brought about by polyclonal antibodies and monoclonal antibodies. So this polyclonal antibodies, by repeated injections of human thymocytes and lymphocytes into the animals such as horses, rabbits, and sheep, there is wide variability in efficacy and toxicity. So these polyclonal antibodies are produced by repeated injections of human thymocytes and lymphocytes into the animals such as horses, rabbit, and sheep. But these polyclonal antibodies have a wide variability in the efficacy and toxicity. Then we talk about monoclonal antibodies. They are developed by a process called as hybridoma technique. and the antibody of a defined specificity. So these monoclonal antibodies are the antibodies of defined specificity. Now, when you talk about this anti-thymocyte globulin, this anti-thymocyte globulin is purified gamma globulin derived from the serum of rabbits. So what are the mechanism of action of this anti-thymocyte globulin? So this mechanism of action is they act by containing the cytotoxic antibodies that bind to CD2, 3, 4, 8, CD11A, CD18, CD25, CD44, CD45 and HLA class 1 and 2, that is human leukocyte antigen class 1 and class 2. And these antibodies deplete the lymphocytes by direct cytotoxicity. So what are the therapeutic use of these antibodies, poly and monoclonal antibodies? They are especially, the therapeutic uses are, they are used for the induction of immune suppression. They are used in acute renal transplant rejection in the dose of 1.5 milligrams per kg per day for 7 to 14 days. That is the monoclonal antibodies. Then when you look into the toxicity of these monoclonal antibodies, like we have the hypotension, leukopenia, thrombocytopenia, serum sickness, and glomerulonephritis. And this monoclonal antibodies, there are various types of monoclonal antibodies available, like anti-CD3 antibody. So these antibodies which are directed at the epsilon chain of the CD3 pathway, and they are derived from original mouse IgG2A. They are muromonab CD3, which is still used in the glucocorticoid resistant rejection. The mechanism of action of monoclonal antibodies are, they are rapid internalization of the T cell receptor occurs, preventing antigen recognition. So they cause rapid internalization of T cell receptor, preventing antigen recognition. They cause margination of the T cells. They reduces the function of other T cells, monoclonal antibodies. Coming to the therapeutic uses and adverse effects, they are available as sterile solution containing 5 milligrams per ampule, and the dose is 5 milligrams per day in a single intravenous bolus for 10 to 14 days, and it is repeated use of muromonab is contraindicated as it decreases the immunosuppressive effect. Coming to the toxicity or adverse drug reactions, they cause cytokine release syndrome. They also causes increase in the TNF alpha, IL-2, IL-6 and IFN gamma, that is interferon N gamma. They also cause fatal pulmonary edema, and they also cause acute respiratory distress syndrome, the monoclonal antibodies. So they cause cytokine release syndrome, increase TNF alpha, they increase the release of IL-1, IL-6 and IFN gamma. They cause fatal pulmonary edema, acute respiratory distress syndrome. Then anti-interleukin 2 antibodies. So anti-interleukin 2 antibodies are daclizumab, basiliximab, human and murine chimeric monoclonal antibody, and this daclizumab has 90% human IgG1 and 10% murine CDR. And mechanism of action of this particular anti-IL-2 antibodies are, they bind to anti-CD25 monoclonal antibodies to the murine antibodies to the interleukin 2 receptor on the surface of the activated T cells. There is a moderate decrease in the circulating lymphocytes, and alpha and beta chains of anti-CD25 are downregulated. So these are various mechanism of action of the anti-interleukin 2 antibodies like daclizumab and basiliximab. Now coming to the uses of these anti-IL-2 antibodies, They are used for prophylaxis of acute organ rejection. The dose is in 5 doses, 1 milligram per kg IV over 15 minutes in 50 to 100 ml of normal saline, and then it can be used bi-weekly. The plasma half-life is 20 days. For basiliximab, the dose is 20 milligrams pre-operatively and on days 0 and 4 after transplant. The plasma half-life is 7 days. The toxicity of this particular basiliximab and daclizumab are anaphylactic reactions. Then we have anti-TNF agents. So what are these anti-TNF agents? So there is a raised TNF seen in rheumatoid arthritis, Crohn's disease. And the drugs which are used for the treatment of Crohn's disease and rheumatoid arthritis are infliximab, which is a chimeric anti-TNF agent. It has a human constant region and murine variable region. So infliximab, which is used in rheumatoid and Crohn's disease, is a chimeric anti-TNF agent with a constant human region and a variable murine region. It prevents binding of the cytokines. It also is used in ankylosing spondylitis, the plaque psoriasis, psoriatic arthritis, and ulcerative colitis. The other anti-TNF agents are etanercept. So what is this etanercept? So this etanercept is containing a ligand binding portion of human TNF alpha receptor and the FC portion of IgG1. And this particular etanercept, it is used in the treatment of rheumatoid arthritis, psoriasis, and arteriosclerosis. Then not only that, adalimumab. Adalimumab, it is a recombinant human IgG1 created by a phage. Now we have this IL-1 inhibitors, interleukin-1 inhibitors, that is the plasma interleukin-1 levels are increased in patients with active inflammation. And the drugs which are acting by inhibiting the interleukin-1 are anakinra. So this anakinra, it is a recombinant non-glycosylated form of human interleukin-1 receptor antagonist. Okay, then we have canakinumab. This canakinumab, it is an interleukin-1 beta monoclonal antibody which is used in familial cold autoinflammatory syndrome and McIlwell syndrome. That is, it is used in 2 conditions, canakinumab, that is familial cold autoinflammatory syndrome, and McIlwell syndrome. And we have another drug which is called as rilonacept. It is actually in the phase 3 of clinical trials, which will be used in the treatment of gouty arthritis. Then we have lymphocyte function associated antigen 1 inhibition. Lymphocyte function associated antigen 1 inhibitions. The drug is afalizumab. It is also called as Raptiva. Afalizumab or Raptiva, it is a humanized immunoglobulin G1 murine antibody targeting CD11, a chain of LFA1 antigen. The mechanism of LFA is nothing but lymphocyte function associated antigen 1 inhibition and prevents LFA1, binds to LFA1 and prevents LFA1 and the intracellular adhesion molecule interaction and blocks the T cell adhesion. It blocks the trafficking and activation of the T cells. Then we have another drug which is called as alifacept. Alifacept, it is a human lymphocyte function associated antigen inhibition 3 IgG1 fusion protein. That is, it is a human LFA3 IgG1 fusion protein. And LFA3 portion of elaficept binds to the CD2 on the T lymphocytes and interfere with the T cell activation, and they cause a dose dependent reduction in T effector memory cells. Then we have the another entity which is called as co-stimulatory blockade. So what is this co-stimulatory blockade? This co-stimulatory blockade is to induce tolerance to maintain active state of antigen specific non-responsiveness. It is to induce tolerance to maintain active state of antigen specific non-responsiveness, especially H1F1 and H3D1 are humanized anti-CD8 and anti-CD86 murine antibodies. Okay, and in this particular co-stimulatory blockade, we have a drug which is called as abatacept. This abatacept CTLA4 Ig has binding region of CTLA4 and constant region of human immunoglobulin G1. It also inhibits the CD28. We have belatacept. So this belatacept, it is a second generation CTLA4 immunoglobulin with 2 amino acid substitutions. It has higher affinity to CD80 and CD86. It is administered intravenously, and it is associated with associated with post-transplant lymphoproliferative diseases. Then we have the recent approaches in this immune suppressants are, that is, the recent approaches are donor cell chimerism, soluble HLA, human leukocyte antigens, and we have antigens. Then we'll go to the next major topic, which is called as immunostimulants. The immunostimulants are levamisole, thalidomide, lenalidomide, Bacillus calmette-guerin or BCG, recombinant cytokines. Then we have the immunizations or the vaccine and intravenous immune globulin. Now, when you look into this levamisole, these are the immune stimulants. So levamisole, primarily it is an anti-helminthic drug which restores the depressed immune function of the beta cells, so B cells, T cells, monocytes and macrophages. The therapeutic use of levamisole is mainly used in the colon cancer along with 5-fluorouracil. The adverse drug reactions are fatal granulocytosis. Then we have thalidomide. Thalidomide, primarily the mechanism of action of thalidomide is, it is primarily an anti-inflammatory drug. It is also an immunomodulatory drug, and it is also an anti-angiogenic drug. So as an anti-inflammatory and immunomodulatory, definitely its use is utilized, especially in the treatment of patients with erythema nodosum leprosum in leprosy, lepra-2 reaction, and multiple myeloma as an anti-inflammatory and immunomodulatory. And anti-angiogenic action especially is by inhibiting the cyclooxygenase 2 and by inhibiting the biosynthesis of PGE2, which is needed for angiogenesis. So this particular thalidomide, it is also an anti-angiogenic drug by inhibiting the cyclooxygenase 2 enzyme, whereby it inhibits the biosynthesis of prostaglandin E2, which is needed for angiogenesis. So apart from anti-inflammatory and immunomodulatory actions of thalidomide, it is also used as an anti-angiogenic drug. So the mechanism of action is, it decreases the production of TNF alpha in erythema nodosum leprosum patients, and the adverse effects are the life-threatening birth defects and teratogenicity. Then we have another drug which is called as lenalidomide. So it is an immunomodulatory and anti-angiogenic drug. The therapeutic uses are, it is used in the treatment of myelodysplastic syndrome, especially in the dose of 10 milligrams per day. The adverse drug reactions are, it causes deep vein thrombosis, neutropenia, thrombocytopenia, and teratogenicity. Then coming to the other drugs like recombinant cytokines. So these recombinant cytokines in the form of interferons. So these interferons, they cause induction of enzymes, they cause inhibition of cell proliferation and enhancement of immune activities. So these are immune stimulants. So interferons, they cause increased phagocytosis, they cause increased cytotoxicity. So we have interferon alpha 2b, that is intron A, obtained from E. coli, which is used in the treatment of hairy cell leukemia, malignant melanoma. And we have interferon gamma 1b, which is called as actimmune, and this we have interferon beta 1a, interferon beta 1b, and this interleukin 2, the drugs which are acting on interleukin 2, that is aldase leukin. Aldase leukin, it is produced from E. coli in the form of non-glycosylated. It is not glycosylated. It causes enhancement of lymphocyte proliferation and induction of interferon gamma activity. It is used in the treatment of adults with metastatic renal cell carcinoma and melanoma. And we have the very important drug, that's the latest drug, that is glatiramir acetate. Glatiramir acetate, which is the latest drug available, which is actually a synthetic copolymer with immunological similarity to myelin basic protein. So glatiramir acetate, it is a synthetic copolymer or with immunological similarity to myelin basic protein. It is given as subcutaneous preparation, and it is claimed to reduce the relapse rate in relapsing remitting multiple sclerosis. It is a immunomodulator. So these are all the drugs which are available as what you call as the immune stimulants. So immune stimulants, we have looked into immune suppressants, we have looked into immune stimulants, and we have looked into the monoclonal antibodies. So we have dealt with levamisole, thalidomide, lenalidomide, BCG. So Basil calmette guerin, or BCG, it is an immune stimulant, is a vaccine. And of course, we have various vaccines which are available for the to increase the immune status, or it causes, they are the immune stimulants like vaccines. Various vaccines like OPV, DPT, BCG, all these things, all vaccines are the immune stimulants. So I think with this probably we have covered the immune suppressants, which are the mainstay in the treatment of graft graft host rejections, and then immune stimulants, especially in immune deficiency syndromes. And then we have this immunomodulators, which are used in the autoimmune disorders like the glucocorticoids and all those things. And we have last drug, that is glatiramir acetate, which is an immunomodulator, which is claimed to reduce the relapse rate in the relapsing remitting multiple sclerosis. And with this, we come to the end of the talk, that is the immunopharmacology, where we have dealt with the immune suppressants, immune stimulants, like they have come, they are dealt in broadly in the immunomodulators as immunomodulators, and the tolerogens. Thank you.